Welcome to ATCM, the emergency medicine channel.
Yes.
A 50-year-old female present to the ER at around 7 a.m. with complaints of decreased response. On our initial 10-second assessment, patient was drowsy, not obeying commands. Coming to airway was patent, no pooling of secretions, no gurgling. Coming to breathing, respiratory rate of 20 per minute, saturation of 98% in room air. Coming to circulation, pulse rate of 80 beats per minute, BP of 130/80 millimeters of mercury, all peripheral pulses equally palpable. Coming to disability, GCS of E2, V2 and M5. Coming to exposure, temperature of 98.6 degree Fahrenheit and GRBS of 30 milligram per deciliter. At this point of time, injection dextrose 25% IV stat was given. And GRBS was reassessed, which was found to be 220 milligram per deciliter, and IV fluid DNS was started at 100 ml per hour. Adjuncts to primary survey, PBG was taken showing a pH of 7.392, PCO2 of 43, bicarb of 23, lactate of 2. Coming to ample history, a 50-year-old female, no previous comorbidities, present to the ER with complaints of decreased response since 7 am. The patient had taken food at around 10 pm, went to sleep, and morning the bystanders went to wake up this patient, found to be drowsy, and brought to the ER. No history of any deviation of angle of mouth, vomiting, involuntary micturition, weakness, loss of weight, evening rise of temperature, fever. The bystanders give history that the patient is having generalized tiredness and sweating and tremors for the past 1 to 2 months, which worsens on fasting and relieved after taking food. But it has not been evaluated.
What is the age of the patient?
50, sir.
50.
On reassessment,
All symptoms come after food?
before on prolonged fasting, that was
Prolonged fasting. Okay. Can any patient develop hypoglycemia immediately after food?
Yes, sir.
What is that?
Postprandial hypoglycemia can be classified in different types. Okay. One is fasting and postprandial hypoglycemia.
Postprandial hypoglycemia is seen in which type of?
Dumping syndrome, where gastrectomy patients has been done. And,
so that's a post-surgery non-adverse effect. Other than that is...
Nesidoblast.
Somebody develops hypoglycemia symptoms. They may not develop hypoglycemia after food, immediately after food. What that indicates? Some patients' pancreas will be hyperstimulation of pancreas. This type of patients in future, they may develop diabetes. Immediately after food, they develop a surge of insulin release, and they may go to hypoglycemia. Before the sugar entering to the body, their insulin will act. Okay. That is hyperstimulation of pancreas. That type of patients, there is a chance of becoming diabetic after some time. Okay, not always. Okay, so that is postprandial hypoglycemia.
Coming to medical history, the patient is currently not on medications. Coming to past history, no similar episodes in the past. The last meal was taken at 10 p.m. in the night. Coming to systemic examination, and now the GRBS was 220 and the patient was conscious oriented, power 5/5 on all the 4 limbs, GCS was 15/15. Systemic other examination was within normal limits. So our primary diagnosis was a spontaneous non-diabetic hypoglycemia under evaluation.
Okay. What do you mean by spontaneous hypoglycemia?
Spontaneous hypoglycemia means in non-diabetic patients suddenly developing symptoms.
Non-diabetic. Non or non? Non-diabetic patients suddenly developing hypoglycemia is spontaneous. What are the other reasons for spontaneous hypoglycemia? What are the reasons for hypoglycemia? Then you will divide into spontaneous and non-spontaneous.
Most common cause if the patient is on any
OHA or insulin.
Okay. In not a non case of any diabetes, then the most common causes can be alcohol can be a cause.
Okay.
And infections like malaria can cause.
Normally, alcohol increases the blood sugar. Alcohol sugars cannot be stored, but it suddenly increases the blood sugar. What scenario in alcohol can produce hypoglycemia? What are the problems in alcohol they can develop hypoglycemia?
Liver disease.
One is patient developing a liver disease can have hypoglycemia. Second one, alcohol itself can produce. How it produces? So somebody is taking regularly, every day he is taking alcohol, his blood sugars will be very high. that cannot be stored, but it will be very high. Suddenly, 1 or 2 days, he is withdrawing the alcohol, the sugars will drop to a normal or below normal. He will develop all symptoms of hypoglycemia. Okay, so that is alcohol. Then
other like drugs like quinine.
Quinine. Okay, one is quinine. Then
Disoropyramide.
Gatifloxin, one drug was there, now it is withdrawn. Okay, that can produce sometimes. Then
Hormonal deficiencies,
which hormone?
adrenocortical insufficiencies
Okay.
can cause hypoglycemia. Then endogenous hypoglycemic symptoms like primary beta cell tumors, autoimmune hypoglycemia.
Okay. So what are the counter-regulatory hormones against insulin? Counter-regulatory means insulin reduces the sugar. Some hormones increases the sugar. What are the hormones?
It can be most common is glucagon.
Glucagon. Glucagon is produced from
Pancreas.
which cells?
Cells of the
Alpha cells. Okay. Glucagon is the most important. Then
cortisol,
adrenaline. Okay, like that many hormones try to balance insulin. That most important is glucagon. Okay, so glucagon can be over secreted sometimes. From where?
In tumors itself, like glucagonoma.
Insulinomas. Okay, so that can produce from the this one. Okay, so the malaria, any other infection other than what you told, infections which can
infection like sepsis.
Malaria is one important thing. Then sepsis.
TB causing
Tuberculosis, very rarely it produces more of hypotension shock. Sometimes hypoglycemia can occur. Okay.
Then the patient was further evaluated in view of the spontaneous hypoglycemia.
Okay.
So
when you are seeing a patient who is having hypoglycemia, you already know that patient is not on any anti-diabetic medication. What is the first investigation you draw from the patient? Blood.
CBC, CRPs are basic.
CBC, CRP is not required. Somebody is developing hypoglycemia, suddenly all of a sudden who is healthy, not diabetic.
Serum insulin
And
C-peptide.
Insulin and C-peptide. What is the difference between insulin and C-peptide?
C-peptide is a precursor.
So you just imagine you are a doctor. You are taking insulin, knowing that it can produce hypoglycemia. Due to some reason, you are taking 100 units of insulin. What will happen to you?
There will be hypoglycemia.
You develop
Hypoglycemia.
But sometimes it will be branded as spontaneous hypoglycemia. If you don't give the history, it will be spontaneous hypoglycemia. If I take C-peptide in you, what will happen?
Will be normal.
C-peptide will be normal, whereas in insulinomas, both C-peptide and insulin will be high. Okay, that is a difference. If somebody takes an insulin and we get a history that it is spontaneous hypoglycemia, if C-peptide is normal, insulin levels are high, that means he has taken insulin. Okay, so C-peptide also has to be taken to make a diagnosis. Okay, so somebody come to emergency room with hypoglycemia, immediately draw a sample for serum insulin and C-peptide. Okay.
So in this patient, basic routine investigations was done along with chest X-ray, USG abdomen, and along with that serum C-peptide and serum insulin level was done.
Okay.
And following that, it was evaluated, and the serum basically when patient come with hypoglycemia, serum insulin level has to be taken in that episode of hypoglycemia.
Okay. During hypoglycemia, you have to take
that. Then based on that, there can be
suppose without knowing all these things, you give dextrose, what will happen? What will happen to the patient? Patient improves. Definitely you are treating the patient improves. He will go to ward. Then what will happen?
Recurrent hypoglycemia.
Then the doctor has to produce hypoglycemia. How do we produce hypoglycemia? He asks the patient to have a prolonged fasting, more than 24 hours. May develop sometimes for 36 hours. So patient has to suffer. So before doing that type of investigation, you can simply take a insulin C-peptide from emergency room itself, if you know about this insulinoma problem. Okay. So there is advantage. It's an advantage for the patient and treating physician in ward.
So serum insulin level can be raised or decreased.
Okay.
Raised, then it is hyperinsulinic hypoglycemia. That is the most common.
Okay.
In this case, it was raised insulin.
Okay.
So it comes under hyperinsulinemic hypoglycemia.
Okay.
Then based on C-peptide or proinsulin levels, we again classify it as whether it can increase or decrease. If serum insulin is decreased, then exogenous hyperinsulinemia is the most common cause, exogenous production. Whereas it is increased, that is endogenous hyperinsulinemia is the common cause.
Exogenous means we are giving insulin. Okay.
Then in this case, both C-peptide.
Because many suicidal intentions, somebody like family, somebody is taking insulin. For suicidal intention, many patients are taking insulin. That we should remember. That's why this classification has come.
So in this case, C-peptide and serum insulin level was elevated. So our diagnosis got narrowed. We are suspecting a beta cell.
See, if you take malaria, quinine can produce hypoglycemia, malaria can produce hypoglycemia. What is the mechanism of quinine which produces hypoglycemia? Quinine is a secretagogue. What is secretagogue? It increases the secretion. It mimics sulfonylurea. It increases the secretion of insulin from the pancreas. So it increases the secretion. Whereas malaria, how it produces hypoglycemia? It utilizes the sugar. So that both are different. Malaria utilizes the sugar and produces hypoglycemia. Quinine increases the secretion of pancreas, insulin, and that produces hypoglycemia. That's why whenever we are giving quinine, nowadays we are not giving quinine. Whenever we are giving quinine, it should be continuously in dextrose infusion, and if after the dextrose after the quinine infusion we have to continue dextrose infusion. Okay, so quinine producing hypoglycemia mechanism is different from malaria.
In this case, both serum insulin and C-peptide levels were increased. So we were suspecting endogenous hyperinsulinemia. In that comes primary beta cell tumors and autoimmune causes. And we have also sent auto antibodies, and also we went for the imaging. The imaging came out to be showing lesions in the pancreas, which were evaluated later suggestive of insulinoma. If we are seeing a normal imaging and we are seeing symptoms of hypoglycemia, the next we have to go with autoantibodies. Autoantibodies is now a most common cause of non-diabetic insulin, because most drugs like methimazole and other drugs used for thyroid disorders can cause hypoglycemia. Even multivitamins can trigger hypoglycemia. The mechanism in autoantibody is like there can be hyperglycemic episodes, hyperglycemia and hypoglycemia. This is basically they are having a high binding capacity and low affinity. So when there is hypoglycemia, there is increased production of antibodies that bind to the immune insulin receptors, and there is hypoglycemia. But due to low affinity, later it gets dislodged, and in order this there is counter-regulatory insulin production also. So due to increased excess production and low affinity where antibodies are removed, that again causes hyperglycemia. So autoantibodies has to be in case of hyperglycemia and hypoglycemic episodes. In this case, it was insulinoma, which were later evaluated.
What investigation will pick you that insulinoma?
CT, and we can go ahead with medical investigations like 72-hour fasting, but due to prolonged fasting, that is not recommended nowadays. 72 hours of fasting, we will give 1 milligram of glucagon, where there can be a more than...
What is the action of glucagon?
Insulin, glucose production, sir.
So it produces hyperglycemia.
More than 25 milligram per deciliter in next 25 to 30 minutes, suggestive of insulinomas. And there is a triad where there can be symptoms of hypoglycemia, and recorded sugars should be less than 50, and the symptoms improve after taking food.
What is that triad called?
Whipple's triad. But that is not specific for insulinoma.
It can be seen in all type of hypoglycemia. But in a spontaneous hypoglycemia, if this triad is there, that indicates mostly an insulinoma. What happened to the patient afterwards?
The patient is currently admitted and planning for further investigations and management.
So they'll be planning for removal of tumors.
Discussing with the GA surgery consultants.
What are the other reasons for hypoglycemia in a non-diabetic patient? Diabetic patient can have hypoglycemia. So how do you handle that situation? Somebody is having diabetic for a long time. He is on insulin like 20 mixed heart. So he develops hypoglycemia recently. What all things you look into that patient? How do you manage that issue?
Basically, we have to look at the drugs that are taken for hypoglycemia. Either it can be increased insulin beyond the requirement, or can be OHS like
Yeah,
sulfonyl
for a
ureas.
long time, his sugars are controlled. Recently, his requirement of insulin is coming down. So, what is the first thing will come to your mind?
Loss of appetite, patient diet.
He's not taking food. Okay, that's okay. You advise him to take food. That is one thing. Second thing,
Infection, the requirement of insulin.
insulin increases, no? Sugar increases. What is the most important thing you ask for a new investigation in that patient?
HbA1c for
Creatinine.
creatinine.
Why creatinine?
Because insulin can prolong if there is a real impairment.
Insulin excretion is through the kidneys. If kidneys are damaged, excretion will be
Long.
delayed. Okay. So that time insulin requirement will come down. So any patient is on long-term insulin, he was on a steady unit for a long time. Suddenly if requirement is coming down means mostly he might have gone to renal failure and requirement comes down. Okay. In that case it is better not to use long-acting insulin. Okay. Better not to use the drugs which can produce hypoglycemia. What are the drugs which can produce hypoglycemia among anti-diabetic patients? Anti-diabetic drugs, most important drugs.
Sulfonyl ureas.
Sulfonyl ureas are the most important drugs that can produce prolonged hypoglycemia, like glibenclamide. All these things can produce prolonged hypoglycemia. How do you tackle that issue?
We either can shift to if the renal failure is there, metformin is also not indicated.
Okay.
And we can start on short-acting insulin. Insulin therapy can be started.
Okay.
And continuous monitoring of GRBS.
Suppose somebody is developing repeated hypoglycemia. His HbA1c is very high, 9, but he is developing hypoglycemia. How do you tackle that issue?
We have to look at the 3 a.m. sugar level.
Repeated means morning, repeatedly morning, afternoon, he is developing hypoglycemia. What do you do for that? See, these are common issues. Patient will come with hypoglycemia. He tell 2-3 times I had low sugar, but his HbA1c is very high.
We have to look
That
at
means
the time between insulin given and the time of taking food. Ask him to give insulin and immediately.
So ask him to take frequent small diets in between the major meals so that you can avoid hypoglycemia. Still you can increase the dose of insulin. Second problem in ICU will be very high blood sugar in the morning. How do you tackle that issue?
We have to look at the 3 a.m. sugar
So
levels.
how do you help? How do you help?
Omega and down.
What is omega and down?
One is due to excess insulin production. One is due to deficiency. So
omega is what?
Excess insulin production.
So omega is morning hypoglycemic. Post hypoglycemic hyperglycemic. So morning its sugars are very low. So that counter-regulatory hormones will produce very high blood sugar in the morning time. Early morning means 2 o'clock it will be very low. 7 o'clock it will be high. In that condition, what you do?
Decrease the night
decrease the night dose. Whereas other one Down's phenomenon.
To increase the night dose.
So morning itself it is high. 3 o'clock it is high. 7 o'clock also it is high. So increase the night dose. Okay. What is hypoglycemia unawareness?
In patients having hypoglycemia, but seeing symptoms like in early morning, patients having fatigue, altered
hypoglycemia unawareness. You are telling night hypoglycemia can produce early morning fatigue, headache, weakness, inadequate sleep.
Patients having symptoms of hypoglycemia.
Hypoglycemia unawareness. What is it? You have hypoglycemia but no symptoms. Where will you get that?
In beta blockers.
Okay. What is new? There are 2 types of symptoms hypoglycemia can produce. What are they?
Neuroglycopenic symptoms and neurogenic symptoms.
What are neurogenic symptoms?
Can be tachycardia, palpitations, tremors like
so
that.
if you give beta blocker, what will happen?
Mask the symptoms.
They mask the symptoms. So in a diabetic patient, it is better to avoid beta blocker because it can mask the symptoms of hypoglycemia. So in which condition diabetic patient beta blockers are compulsory we have to give? They are compelling indications. We give beta blocker in many patients in ICU. Which condition? They are compelling indication. Beta blockers in diabetes. It's not a first line drug. You should never use diabetic beta blockers as first line antihypertensive in diabetic patients. All ACE inhibitor, ARBs, all these things we give.
Renal failure.
Renal failure, it is not indicated. Again, ACARB can be given to prevent renal failure. Once the patient develops renal failure, calcium channel blockers are used. If the patient develops CAD, that is the indication. The patient develops acute MI, ischemic heart disease, then it is a compelling indication for beta blockers. Otherwise, beta blockers better avoid in diabetic patient. That also we should know. So here, if we have a patient, young patient who is having spontaneous hypoglycemia, who is not having diabetes, without insulin, suddenly developing hypoglycemia, we have to take along with your treatment. So treatment cannot be delayed. You have to start treatment, then you have to take 2 investigations. One is serum insulin, C-peptide. Suppose he had taken insulin with suicidal intention, the insulin level will be high, C-peptide will be. If he is having a problem like insulinoma, both insulin and C-peptide levels will be very high. If both are very high, we have to do at least a CT scan to rule out insulinoma. Okay, other than other investigations which are available, any other investigations are available to see that nuclear medicine scanning?
MRCP.
Nuclear medicine, they can do scanning and find out where all these insulinomas are there. Suppose there is an insulinoma in pancreas, we can pick up by CT. So some other areas we can pick up by nuclear medicine scan. Okay, thank you.